mild ascites and pleural effusion and renal calculi. USG done in March. A parathyroid scan was performed in the December episode, which also did not detect any adenoma. USG abdomen performed in December 2020 had the similar investigations for hypercalcemia were done, which showed a normal to low phosphorus level, a low vitamin D level, and a 24-hour urinary calcium, which was high normal. The BMD scan, that is bone mineral density scan, was done in the November 2020, and it showed osteoporosis with a t-value of less than -2.5. So summarizing, we have a 35-year-old female who is non-alcoholic, non-smoker, who presented to a tertiary care center with recurrent episodes of epigastric pain with back radiation, probably 4 episodes in 1 year, with back biochemical and with biochemical and radiological evidence of pancreatitis, with biochemical evidence of hypercalcemia and hyperparathyroidism. So a diagnosis of recurrent acute pancreatitis, hypercalcemia related, probably due to hyperparathyroidism, was kept first, and the possibility of pancreas divisum, though the etiology is controversial. Coming on to management, for the first 3 episodes, the patient was managed with IV fluid, furosemide, bisphosphonate, and antibiotics and other supportive treatment. For the fourth episode, patient was managed with IV fluid, furosemide, antibiotics, and in this episode, the patient had undergone a parathyroid surgery after a multidisciplinary consultation. I would like to hold your thoughts on this. We'll come to this at the end of the discussion. So today we'll be discussing about recurrent acute pancreatitis. So by definition, it is more than one well-documented and separate attack of acute pancreatitis that is completely or near completely resolved with more than 3 months in between the 2 attacks. Moreover, there should not be any definitive evidence of underlying chronic pancreatitis or persistent fluid collection on imaging as a consequence of the previous attack. So, what are the recurrence rate of pancreatitis after an initial episode of acute pancreatitis? So, as per the 3 studies, one by Zhang et al., Gulu et al., and Gao et al., who registered 245, 1068, and 1471 patients respectively. So the rate of recurrence was ranged from around 11 to 32%, and the most common etiologies being alcohol-related, biliary, and idiopathic causes. So what are the etiologies for recurrent acute pancreatitis? So toxic etiology, it includes alcohol and drugs. Obstructive, which includes gallstone, microlithiasis, and pancreatic biliary tumor. Metabolic, which include hypertriglyceridemia, hypercalcemia, vascular disorders like vasculitis, hereditary and genetic disorder, idiopathic, and miscellaneous. Out of these, alcohol, gallstone, and idiopathic remain the common causes of recurrent acute pancreatitis. Some possible or controversial etiologies include pancreas divisum, sphincter of Oddi dysfunction, choledochocele, and annular pancreas. Coming on to alcohol, the prevalence among the chronic alcoholics is 16.9% in male and 5.5% in female that lead to recurrent acute pancreatitis. Those literature suggests that there is some underlying chronic pancreatitis, but we have studies that support that that recurrent acute pancreatitis occurs in patients who do not have any concrete evidence of chronic pancreatitis. And this occurs in more commonly in patients who are heavy drinkers, higher chances of progression to chronic pancreatitis, and smoking is an additive risk factor and also an independent dose-dependent risk factor for chronic pancreatitis. Gallstone disease, it is one of the common causes, though one must think that after cholecystectomy, the chances of developing pancreatitis are rare, but we can see recurrence in about 4.4% patients treated with cholecystectomy, 6.7% patients treated with endoscopic sphincterotomy, and 1.2% patients treated with both. Microlithiasis, it is one of the leading cause in patients who have idiopathic recurrent acute pancreatitis. Microlithiasis are gallstones which are less than 3 mm and are not visualized by the routine ultrasound abdomen. And they develop into gallstones which are detected in about 75% of patients in follow-up USG within 6 months. The best diagnosis is done by EUS with a sensitivity of 96%, and it must be suspected in patients who present with an abnormal LFT within 24 to 48 hours of presentation. Hypertriglyceridemia. It is an uncommon cause of recurrent acute pancreatitis, and prevalence and mechanism are unknown. The triglyceride levels must be more than 1000 milligram per deciliter for pancreatitis. And recurrent acute pancreatitis develops in patients with hypertriglyceridemia when it occurs with other causes like cystic fibrosis and or alcoholic pancreatitis. Hypercalcemia. The cause is uncommon, but it is a treatable cause. It must be ruled out in a quiescent phase because in an acute episode, there are chances that the serum calcium might decrease in patients with acute pancreatitis. And evaluation for parathyroidadenoma is prudent in absence of other causes. Drug induced. Various drugs are implicated like azathioprine, fibrates, furosemide, ACE inhibitors, L-asparginase, and antiretroviral therapy. The list is long, but due to the want of time, I have just mentioned few. Cause and effect relationship difficult to demonstrate, and the time duration between exposure and onset of pancreatitis is variable. The mechanism seems to be idiosyncratic, and re-challenge is not feasible in such patients. Pancreatic or biliary tumor. These are uncommon but important cause of recurrent acute pancreatitis. Prevalence is about 2 to 7% and should be considered in patients older than 50 years in whom the etiology could not be identified. Tumors like periampullary tumor, pancreatic adenocarcinoma, neuroendocrine tumor, intraductal pancreatic mucinous neoplasm are the common ones, and they are diagnosed by CT, MRI, or EUS. Autoimmune pancreatitis. The type 2 autoimmune pancreatitis results into recurrent acute pancreatitis, but the cause is rare. Type 1 presents as a painless jaundice, and IgG4 levels can help for the diagnosis. Now coming on to hereditary or genetic causes. So the gene mutations in hereditary pancreatitis are one is catanic trypsinogen gene mutation, second is serine protease inhibitor, causal type 1, that is SYNC mutation. Third is chymotrypsin C gene mutation, and fourth is CTFR gene mutation. And these lead to progression into chronic pancreatitis. The age of first episode may give us the clue for diagnosis. Moreover, history of pancreatitis in first or second generation relatives is also an indicator. Pancreas division. It is most common congenital anomaly of pancreas. The prevalence among the general population is 5 to 14%. The prevalence increase in patients with recurrent acute pancreatitis, increasing from 8 to 26%. Diagnosis is made by EUS, ERCP and MRCP, and the secretin enhanced MRCP has a higher sensitivity. Now, what is the natural course of recurrent acute pancreatitis? So, recurrent attacks after a single episode occurs in about 26% of the patients, which whoopingly increase after multiple episodes to 49%. So, patient presenting with acute pancreatitis, almost 11 to 32% of them go on to develop recurrent acute pancreatitis. And out of the patients of acute pancreatitis, 3 to 14% go on to develop chronic pancreatitis. So what are the investigations that a patient should undergo? CBC, LFT, triglyceride levels, calcium levels, USG abdomen, CECT abdomen, MRCP without MRI abdomen, EUS, sphincter of Oddi manometry, which is controversial, gene testing, IgG4 levels, and PNK and CNK to rule out vasculitis. Coming on to EUS, it is the first line of investigations in patients presenting with recurrent acute pancreatitis. It detects early changes of chronic pancreatitis, most accurately identifies microliths, and most sensitive for diagnosing small periampullary tumors, which are of less than 2 centimeters in size. Recommendation is to perform EUS after the first attack of idiopathic acute pancreatitis. We have experience of 51 patients who, after the first episode of idiopathic acute pancreatitis, underwent EUS, and we found a 51% of positivity rate to identify the etiology. And timing should be at least 2 to 3 months after resolution of an acute episode of pancreatitis. MRCP, it is used to diagnose ductal anomalies such as pancreas division, anomalous pancreatobiliary duct union, choledococele, ductal obstruction, and changes of chronic pancreatitis. A secretin enhanced MRCP is better as compared to the plain MRCP. Sphincter of Oddi manometry, it is controversial. It measures the sphincter of Oddi pressure during ERCP, and more studies are required to authenticate its use. Gene testing, it is useful in suspicion of hereditary pancreatitis or chronic cystic fibrosis and patients with idiopathic recurrent acute pancreatitis to reduce the further testing. Now the level of investigations. Level 1 includes LFT within 48 hours of pancreatitis, serum calcium level, serum triglyceride and USG abdomen. Level 2, EUS and MRCP. And level 3, gene testing and sweat fluoride levels. Now how to manage and approach the patient of recurrent acute pancreatitis. So patient presenting with recurrent acute pancreatitis, first of all, is the patient a smoker or alcoholic or smoker? If yes, then we have to rule out chronic pancreatitis and stop the agent, that is alcohol or smoking. If there is gallstone or LFT abnormality within the first 48 hours of pancreatitis, then the etiology is probably biliary and EUS should be done if the abdominal ultrasound is negative, followed by cholecystectomy or endoscopic biliary sphincterotomy. If both the factors are not present, then the patient is classified as non-alcoholic, non-biliary recurrent acute pancreatitis. So in such patient, a detailed history of drug history and a family history should be carried out, and serum calcium and triglyceride level should be measured. If those are normal, then a patient must undergo a EUS along with a secretin enhanced MRCP, which can detect gallstone or microlithiasis, which can be treated by cholecystectomy. CVD stone, pancreas divisum or choledococele, which can be treated by endotherapy, and tumor, which can be treated by surgery. If normal, then a sphincter of Oddi manometry and other investigations should be carried out. So if the patient has hypertriglyceridemia, then he should be treated by insulin infusion, heparin infusion, or combination of both, plasmapheresis, combined blood purification therapy, high volume hemofiltration and hemoperfusion, and pharmacotherapy with fibrates, statins, niacin, and omega-3 fatty acids. Now, since our patient had hypercalcemia, I will be discussing a bit detail about the diagnostic modalities. In this, so if the patient presents with hypercalcemia along with increase in the parathyroid hormone, then the patient must undergo USG next, technetium labeled parathyroid scan, sesame SPECT CT, or 4D CT for parathyroid, MRI neck and chest, selective venous sampling of ectopic tissue for the parathyroid hormone, and ultrasound guided FNAC with intact PTH assay in the aspirate. Now, how to treat hypercalcemia? So medically, hydration with saline, forced diuresis with fluids with furosemide, bisphosphonates, calcitonin, cinacalcet, oral glucocorticoid, dialysis in severe patients. And the gold standard treatment is parathyroidectomy. The first benefit is that it reduces the recurrence of hypercalcemia and hence the pancreatitis episode, and it also relieves the symptom and severity of pancreatitis. So what are the indications of surgery in a patient with hyperparathyroidism? All symptomatic patients must undergo, and all asymptomatic patients with serum calcium level of more than 1 milligram per deciliter, upper normal limit, the DEXA scan with a score of less than minus 2.5, creating clearance of less than 60, nephrolithiasis or nephrocalcinosis, vertebral fracture in imaging, age less than 50, and 24-hour urine calcium level more than 400. As you can see, out of the 7 criteria, we have almost 5 criteria that were fulfilled in our patient who we are discussing. So protocol for recurrent hyperparathyroidism. So biochemically confirmed or clinical manifestation of hyperparathyroidism are present, and so these patients qualify for re-exploration. And before we go for re-exploration, the analysis of the previous surgical details and the pre-operative laryngoscopy should be carried out. And before we go in for re-exploration, then the planning for pre-operative imaging should also be done. So again, ultrasound of neck and technetium scan should be carried out. If both are positive or ultrasound is positive for the parathyroid detection, then we have a positive localization and we can easily go in for surgery. If both are negative or only a technetium scan is found to be weakly positive, then we should the patient must undergo a 4D CT parathyroid. If the CT is suggestive of any parathyroid adenoma, then we have positive localization and the patient may go for surgery. If the CT is not suggestive of any adenoma, then we have to go for invasive localization, which includes an FNAC with an intact parathyroid assay and selective venous sampling of the ectopic parathyroid tissue. The diagnostic accuracy rate are pretty much high in 4D-CT, selective venous sampling, and the USG guided FNA and IPTH assay in the aspirate. So last few slides. Why did we consider this patient for discussion? So we'll go fast over the management. So our patient was initially managed medically. A workup for hypercalcemia revealed primary hyperparathyroidism, that is high calcium level, high PTH, along with osteoporosis, nephrolithiasis, and a urinary calcium of more than 400 milligram per deciliter. Since no confirmed adenoma was detected on 99 technetium scan, twice, multidisciplinary consultation was done, and it was decided to get a parathyroid surgery, which was explained to the patient and her husband. Intraoperatively, only 3 parathyroid glands were identified and confirmed by frozen section. Even after meticulously dissecting the neck, the 4th gland could not be identified. So as per the discussion with the endocrinologist, all the 3 glands were removed and sent for histopathological examination. So post-surgery, the PTH in this patient continuously remained high with a high normal serum calcium level, and histopathological examination of the resected tissue suggested a normal parathyroid tissue. So we have discussed this patient as it is not only a therapeutic challenge but as well as a diagnostic challenge to proceed further. So what are the issues in our patient? First is when we should consider a patient as medical treatment failure. As we can see, we previously treated the patient medically for the 3 episodes. So a medical treatment failure is considered when a patient presents with the 2nd episode who has failed the medical therapy. So, but we were apprehensive as we could not detect a adenoma on a parathyroid scan. So we continued to treat her medically. But since the 4th episode was a severe episode, after a consultation, we decided to go for a surgical approach. Second, what is if are there any intraoperative modalities which can detect the parathyroid adenoma if not detected previously? So some modalities which can detect intraoperatively which can detect parathyroid intraoperatively are the frozen section, intraoperative parathormone assay, gamma probe, and selective intraoperative ultrasound. But as intraoperative ultrasound was not available at our center at that moment, the patient could not undergo. And what is the further plan of management for this patient? So further plan is to get a 4D-CT for parathyroid, assess TIMI SPECT CT, selective venous sampling of ectopic tissue or gland for PTH if we can find any, and FNA for suspected lesion with the intact parathyroid assay, which is rarely done nowadays. And the final and the gold standard still remains re-exploration along with an intraoperative ultrasound. So since we are clutching to straws, each and every suggestion is invited. So that's all from my side. Thank you. Sorry, sir, I can't hear you.